Hi everybody, welcome back. This week I'm talking about PCOS, or Polycystic Ovarian Syndrome. So what is it? So it's a disease of women because we're the only ones who have ovaries. 1 in 5 of us are affected, so 20% of women, so it's a big problem. Essentially it's a derangement of female and male hormones in the body that lead to the ovaries, which produce eggs every month for when we want to get pregnant, actually producing those eggs but not releasing them. So lots of small cysts build up in the ovaries, and that gives it the name Polycystic Ovarian Syndrome. So what are the symptoms? Well, initially when I see patients, they're quite often complaining of irregular or absent periods. Hair loss, so a loss of hair in a male pattern, so at the temples and at the crown. But at the same time, they may often be complaining of hair growth, so excessive hair growth, again in a male pattern, on the chin or the chest, and that can be quite thick, coarse, dark hair. And obviously that's quite embarrassing and stigmatising. And alongside that, quite severe acne, proper pustules on both the chin, the cheeks, the back and the chest. So again, a very male pattern acne. Infertility, so women who want to get pregnant find that they're not being able to get pregnant. Weight gain, so women with PCOS find it quite hard to shift weight and tend to put it on. And so that becomes a major problem as well, and it actually makes the problem worse, but I'll explain that later. Insulin resistance, so your body generally doesn't handle insulin as well as it should or use it as well as it should, and insulin is the hormone that turns sugar into energy in the bloodstream, so we need it, it's essential. And that insulin resistance, if left untreated, can get worse and worse until eventually it leads to diabetes. So women with PCOS are at higher risk of diabetes. Pelvic pain is quite common because the ovaries can get quite full of these cysts where they never release the eggs, and they become heavy and big and stretch, and they cause pain either on one side of the pelvis or the other or both, and that can be quite debilitating. And all of these things together with the stigma that comes with them can lead to depression and suicide. So it's a really important condition, and we need to know about it and what to do about it, and there are lots of things that we can do about it. There are some other risks associated with having polycystic ovarian disorder. So as I've said to you, diabetes is always a risk, so that's something we need to look out for and try and avoid. High cholesterol, and that leads to things like heart disease and stroke, so it's important to manage that. Problems in pregnancy, so gestational diabetes, premature birth and preeclampsia are all risks. And these are all similar risks to people that have diabetes. Then we have to think about the lining of the womb, because if you're not having periods it can build up. And initially when it builds up, this is called endometrial hyperplasia, so that's an overbuilding of the womb. And that's something that we need to treat and worry about because it can lead to endometrial cancer. So there are some serious risks associated with the syndrome itself. And then because one of the side effects of having PCOS is obesity, you can get obesity-related disorders, and that varies from everything from joint pains through to sleep apnea. So it can impact on all areas of life and also have long-reaching health effects. So it's really important that we manage it well and carefully. So what are the causes? Well, as with so many things in medicine, we don't know the causes. We definitely know there's a genetic link because you're more likely to have PCOS if a family member, a female family member, has it, so a sister, an auntie, a mum, etc. We know that it's abnormal hormonal levels, so there tends to be this insulin resistance that I've already mentioned, which leads to increased testosterone, which is a male hormone, and then that prevents ovulation, and in turn all of this leads to even more insulin, which in turn leads to weight gain, and the weight gain leads to more insulin being produced. So there's a real vicious circle that can develop as well with increasing weight gain and insulin resistance. So we know that there is this insulin connectivity in everything that goes on in PCOS. A family history of diabetes certainly puts you at high risk of PCOS, and certain medications, so medications for example like sodium valproate, that we use in mental health and for epilepsy can lead to a higher risk of PCOS. The effects on life, as I've already mentioned, are far-reaching, so infertility, weight gain, depression, and embarrassment and stigma from all of the side effects of having this condition. So how do we diagnose it? Well, as a GP, it can quite often be a clinical diagnosis almost. We just need to do some blood tests because it's a triad diagnosis. So essentially, you need to have 2 of 3 things to be diagnosed. So the first thing is irregular or absent periods, and that's quite often present. The second thing is abnormal or deranged hormones. So the hormones that we're looking at are testosterone, which is often raised, luteinizing hormone, which encourages your ovaries to release those eggs, and that's often raised because the body's trying quite hard to get your ovaries to do their job. A low SHBG, and this is a hormone that carries other hormones around the body, and that's often low. And then a raised prolactin, which is a hormone which comes from the brain. So we do blood tests to look at these, and if they are deranged and you have irregular periods, that's enough to make the diagnosis. But sometimes people don't have irregular periods, or they don't have deranged hormones, they only have one. In which case we can do an ultrasound of the uterus and the ovaries, and if on ultrasound you've got polycystic ovaries as well as one of the others, then you have a diagnosis. So it's a diagnosis that we're making all the time in GP, and we're quite skilled and used to doing so. So how is it treated? Well, it's managed, not cured. That's the important thing to know. And we do this with lifestyle, so there's lots that you can do to try and help it. Medication, depending on whether or not you want to get pregnant, dictates which medications, and we treat the symptoms. So at the end of the day, there are lots of things that we can do within a GP surgery to actually manage the condition, and if all else fails, you'll get referred to gynecology, and you may even be offered surgery. So in terms of lifestyle, although it's very hard for women with PCOS to lose weight, or certainly harder than those without PCOS, just a 5% reduction in weight loss can actually kickstart the ovaries into ovulating again. So it's really important. And it's important to combine this with exercise because that's all round good for you and your heart and everything else, but it will also help with the weight loss. And stopping smoking is really important too, not just because of the health benefits, but because smoking increases the male sex hormones, or the androgens, within a woman's body. And those are the problem in PCOS. So you want to minimise anything that might increase those. So in terms of medication, if you have irregular or absent periods and you don't want to get pregnant, so that's the first question that we ask, because that dictates where we go, we can actually restore those periods by using the normal methods, so a combined oral contraceptive pill, a progesterone-only pill, or using progesterone to make a withdrawal bleed. So for 10 days of every month, you will take the progesterone, and when you stop you should have a bleed, and that just clears out the lining of the uterus and makes sure it's safe. And then a Mirena coil, because a Mirena coil stops the lining of the uterus from building up, so then we don't have to worry about bleeding, and in actual fact 90% of women with a Mirena coil don't bleed at all after 6 months. So it really does work, and I've had one and it does work. If you are looking to get pregnant, then we have to approach it in a slightly different way, because obviously the pill isn't going to help you get pregnant. So initially we can use medications under the guidance of gynecology, so a lot of these wouldn't be started in primary care. So clomiphene is one of those, and that's actually a drug that competes at the estrogen receptors in the brain and at the uterus and helps kickstart ovulation, and that's often enough to help you get pregnant. A diabetic drug called metformin works really well, and up to 25% of women again can get pregnant on metformin because it kickstarts ovulation and it helps weight loss, and we know it's a safe drug because we've used it for years on people with diabetes. So it's quite an easy medication to use and to actually get things going. Letrozole and tamoxifen are breast cancer drugs, so they're drugs that actually change the way that the body's hormones are balanced, and they cut down the estrogen in the body, and the aim is to actually get things balanced. But this is an area that is much more complex, and you wouldn't be tried on these drugs until you tried clomiphene and metformin. So again, this would be done under the specialist guidance of gynecology. And then you can have gonadotrophins. So by injection you can have follicle stimulating hormone, the hormone that normally comes from your brain to tell your ovaries to release an egg. You can be given this in much higher doses to actually achieve that. And there are good case reports that this works very well indeed. So that's another option. So there are lots of medication options for people with PCOS who want to get pregnant. You have to have sex, of course, and it's important to say this because those drugs aren't going to do that on their own. So, spend time with your partner, have fun, and have sex at least every 3 or 4 days, just in case the ovaries do release an egg and it's there to be fertilised. And many women with PCOS do get pregnant spontaneously. That's the other thing to say. You may not need any of these medications because every now and again your ovaries will throw out a good egg, and if you're having regular sex, you should get pregnant. And then finally, if none of that has worked, and you really are at a stage where you're looking at other options, surgery is an option. And there's something called ovarian drilling, and it is what it says on the tin. The surgeons, via laparoscopy, so pinhole surgery, you won't have a big open surgery, go in and into the ovary, they make lots of tiny holes. So they drill lots of holes, and that's designed to actually kickstart the ovaries into releasing eggs again, and that often works. Then alongside treating infertility or even just having a regular bleed to protect the uterus, we can treat the symptoms that come along with PCOS that are equally distressing. So for example, the hair loss and hair growth that's caused by having too high male hormones or androgens can be treated with various different medications. So one set of those is the specialist combined oral contraceptive pills that are very high in progesterone, and you'll probably know those as Dianet or Yasmin. And they're not licensed for contraception, but they are licensed for acne, and they may help with the hair loss and acne because they suppress those male hormones. There's a blood pressure tablet called spironolactone, which again can suppress androgens, and that would be prescribed by your gynecology team. Probably wouldn't be done at your GP, but your GP could certainly carry it on for you once it's been done. Then there are other medications called flutamide and finasteride, which can also help with the hair growth and the hair loss. In terms of hair growth, there is a cream that I can never pronounce, but I'm going to give it a go, which is not always available on the NHS, I'm afraid. Some CCGs, that's the governing bodies of each area of GP, do allow you to have it, but some don't. And it's called eflornithine. And it doesn't actually stop the hair growth, but it does remove it. But it means you have to use it consistently. And if your area doesn't prescribe it, then I'm afraid you'll have to buy it. And then, of course, for hair growth, there's plucking, laser, threading, shaving, bleaching, and other creams that are well known and recognised on the high street. The thing to say about all of these is none of them are permanent, so you would have to be doing them consistently. Apart from laser, of course, which can be permanent after a while, but doesn't work on blonde hair. So if your hair growth is blonde, unfortunately, that's not an option for you, and it can be quite expensive and not available on the NHS. Then, of course, we have obesity and the problems that come with that, the health problems. So we have a tablet called Orlistat, which is a fat binder, and we can use that to try and help you with weight loss. It does have some unpleasant side effects, so if you are eating lots of fat, you will get diarrhoea. So the only way to avoid the diarrhoea is to cut down the fat, and that will probably help you lose weight anyway. Then, of course, if you have high cholesterol, which goes alongside this, we can give you a statin, which helps bring that down. All of these things you can discuss with your GP, and they'll assess your risk and decide if it's the right thing for you. Acne can be absolutely debilitating, and although some of those earlier medications that reduce the male hormones can help, we can also try things. There's some thunder there, I don't know if you heard that. We can also try acne creams and tablets, antibiotics, which we would use in normal acne, not just in PCOS, so they can work as well. And then if you've got the problems that come with the obesity. So for example, sleep apnea. There are specialised sleep apnea clinics who could do things like non-invasive ventilation. But this is way down the line when things have really got out of control. And the aim for any GP and patient should be not to get that far. So hopefully we would help you along the way so that you don't get to that point where you've got obesity related issues and cholesterol, etc. But there are lots of different things, as you can see, that we can do. Now, alternative treatments. I always try, if there are any out there, to give you some alternatives, because I know lots of you, when you watch my videos, are way down the line and you've tried all of these. So, there's some interesting research coming out on a medication that decreases gonadotrophin releasing hormone. So in turn reduces those sex hormones. At the moment it doesn't have a name, it's called MLE4901. And it binds at a protein receptor called MK3. Now the trials that have been done so far seem to be quite good in terms of relieving symptoms for women and reducing those hormones. And there is a patent pending at the moment for this particular drug for use in PCOS. So that's something that's on the horizon. And I will put the details of it in the comments afterwards so that you can look at it yourself and see what you think. There might be trials going on, and certainly at the NHS website there are some trials of different things for PCOS, so I'll put that in the comments afterwards. There's the thunder again. Then the bioidentical hormones. Now again, this is outside of the NHS because it's an area of medicine which is not as tested, and so I can't evidence it or support it. But I do know that I have colleagues who actually operate in the area of bioidentical hormones, and they approach PCOS as if it's an estrogen dominance. So you've got too much estrogen that is then driving all of the other hormones out of range. And they go about it in a slightly different way, and they try and balance all of the hormones by giving you certain other hormones. But again, if you're at the end of the line and not finding success, it might be worthwhile investigating. I can't endorse it, but certainly I have patients who have used it and have said it works. And then for symptoms, there are lots of different things like relaxation, stress relievers, etc. A lot of people swear by Ayurvedic medicine for the symptoms of PCOS and for getting the body just back into balance. So all of these things, as far as I'm concerned, if they work for one patient, well then that's great for that patient. And I'm never going to poo-hoo it because we're all different and different things work for different people. So I just throw those things out there as ideas for you to investigate. So hopefully I've shown you that PCOS is a disease of women. It's absolutely debilitating, it can be painful, it can be embarrassing and bring stigma, and it can be distressing to the point of depression and suicide. People find their fertility affected, and that infiltrates so many parts of life. Hopefully I've shown you that there are lots of different treatments, from lifestyle to medication to surgery, and then some other not so mainstream treatments. That it is a really important and debilitating condition that I see all of the time, because 20% of women, 1 in 5, are affected. If I've missed anything or you've got any questions, please ask me in the comment box afterwards and I will always answer them. I'm going to put the NHS trials page, the new drug that I mentioned, some of the bioidentical hormone information and any of the other bits that I've mentioned in the box afterwards, like eflornithine. Can't remember if I said that right, and hopefully that will all help. And yeah, thank you for watching again, and I hope this has been helpful. Take care. Bye.